Hello everybody. Welcome to No1doctor channel. Today's video is about abdominal trauma, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like, share our videos, subscribe to our YouTube channel, No1doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Gunshot wounds to the abdomen require exploratory laparotomy for repair of intra-abdominal injuries, not necessarily to remove the bullet. Any entrance or exit wound below the level of the nipple line is considered to involve the abdomen. In very select cases of abdominal trauma due to low-caliber gunshot wounds involving the right upper quadrant, conservative therapy may be used if the patient is properly monitored with close follow-up of clinical signs and serial abdominal CT scans. Stab wounds allow more individualized approach. If it is clear that penetration has occurred, protruding visceral, exploratory laparotomy is mandatory. The same is true if hemodynamic instability or signs of peritoneal irritation develop. In the absence of these signs, digital exploration of the wound in the ER, gentle insertion of gloved finger, and observation may be sufficient. If digital exploration is equivocal, a CT scan is diagnostic. Blunt trauma to the abdomen requires exploratory laparotomy if signs of peritoneal irritation and acute abdomen develop. Otherwise, in blunt trauma one must determine whether there are internal injuries, whether there is bleeding into the peritoneal cavity, and whether the bleeding is likely to stop by itself or will require surgical intervention. The finding that triggers such investigation is the presence of signs of internal bleeding, patient going into shock, with low CVP, with no obvious external source of blood loss. Signs of internal bleeding in a patient with blunt trauma include a drop in blood pressure with fast thready pulse, low CVP, and low urinary output in a cold, pale, anxious patient who is shivering, thirsty, and perspiring profusely. Those signs of shock occur when 25–30% of blood volume is acutely lost, about 1,500 milliliters in the average size adult, and thus there are few places within the body where such large amounts of blood could hide. It cannot do it in the head. A much smaller amount would produce lethal neurologic damage by compression and displacement of the brain. The neck could accommodate a large hematoma, but gross deformity would be obvious on physical exam. Blood in the pericardial sac would lead to pericardial tamponade. The pleural cavities could easily accommodate several liters of blood, with relatively few local symptoms, but that blood could not hide from an X-ray machine. A few hundred milliliters show up on chest X-ray. By virtue of their size, the arms and lower legs would also show gross deformity if they were the site of a 1,500 milliliters hematoma. That leaves the abdomen, thighs secondary to femur fractures, and pelvis in pelvic fractures as the only three places where 1,500 milliliters of blood could hide in a blunt trauma patient who has developed shock. The femurs and pelvis are always checked for fractures in the initial survey of the trauma patient by physical exam, with X-rays if needed. So, the multiple trauma patient who has a normal chest X-ray and no evidence of pelvic or femur fracture has to be suspected of intra-abdominal bleeding when he or she goes into hypovolemic shock for no obvious reason. This has to be proven because the blood loss might have been to the outside, rather than internal. The diagnosis of intra-abdominal bleeding can be made most accurately with CT scan. CT will show the presence of blood, locate the injury that is the source of the blood, most frequently liver or spleen, and even give an idea of how bad that injury is. In conjunction with the patient's response to fluid administration, it allows a decision to be made for surgery or expectant therapy. The patient with minor internal injuries who responds promptly to fluid resuscitation does not need surgery. The patient with major injuries and vital signs that do not improve with fluid resuscitation will require surgery. Even though fast CT scanners are available in level I trauma centers, it is imperative that the patient be hemodynamically stable so that pictures can be taken without all the commotion of continuing resuscitation efforts. The diagnosis of intra-abdominal bleeding in the patient who is hemodynamically unstable has to be made quickly in the ER or OR, at the same time that resuscitation efforts are underway. This is best done with a limited sonogram, known by the acronym FAST. Focused Abdominal Sonogram for Trauma. The test simply confirms that the belly is full of blood, and prompt laparotomy will ensue. FAST has already displaced the older, invasive, diagnostic peritoneal lavage. A ruptured spleen is the most common source of significant intra-abdominal bleeding in blunt abdominal trauma. If all patients are counted significant and insignificant, the liver is a common source. Often there are additional diagnostic hints, such as fractures of lower ribs on the left side. Given the immunologic function of the spleen, every effort will be made to repair it rather than remove it, particularly in children. If removal is unavoidable, truly smashed to pieces, or there are many other life-threatening injuries that preclude the use of operative time for repair, post-operative immunization against encapsulated bacteria is mandatory. Pneumococcus, Haemophilus influenza B, and meningococcus. Intraoperative development of coagulopathy during prolonged abdominal surgery for multiple trauma with multiple transfusions is treated empirically with platelet packs and fresh frozen plasma, approximately 10 units of each. If in addition to coagulopathy there is hypothermia and acidosis, the laparotomy has to be promptly terminated, with packing of bleeding surfaces and temporary closure. The operation can be resumed later when the patient has been warmed and the coagulopathy treated. The abdominal compartment syndrome occurs when lots of fluids and blood have been given during the course of prolonged laparotomies, so that by the time of closure all the tissues are swollen and the abdominal wound cannot be closed without undue tension. In those cases, a temporary cover is placed over the abdominal contents, either an absorbable mesh that can later be grafted over or an unabsorbable plastic to be removed at a later date when closure might be possible. This syndrome may not be evident until the second post-operative day in a patient on whom closure was done, who subsequently goes on to develop distension, with the sutures cutting through the tissues, hypoxia secondary to inability to breathe, and renal failure from the pressure on the vena cava. In that setting, the abdomen must be opened and a temporary cover provided. Damage control laparotomy has become the standard concept that now guides management of the severely traumatized patient, who is subject to consumption coagulopathy, hypothermia, and the abdominal compartment syndrome. These patients can now be identified ahead of time, as surgeons have gained experience with their management. The operation is designed, up front, to be brief. Clamp all the bleeders, temporarily occlude damaged viscera, clean up all the contamination, and get out of there. Then do the rest of the resuscitation, and at a later date go back in and finish the job. Thanks for watching our video, and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Afif Ahmed.